cancer is a malignancy that comes from the lining of the urinary bladder. And it can really come in two different forms. And most people think about non-muscle invasive bladder cancer and muscle invasive bladder cancer as being really quite two separate entities. Both of these, though, are abnormal growths that form on the inside of the bladder lining. The number one presenting symptom for bladder cancer is gross blood in the urine. So the causes of bladder cancer are not always known. The most well-known and modifiable risk factor for bladder cancer is smoking. However, not all patients who have bladder cancer were smokers. Blue light cystoscopy is a technology that we know can help to discover tumors in patients' bladders that we might otherwise miss with white light cystoscopy. And here at USC, we're really lucky to have the opportunity to use blue light both in the clinic during surveillances after bladder cancer and also in the operating room when we're resecting tumors. And we know that when we use Cysview, which is a dye essentially instilled into the patient's bladder, we're able to pick up about 20% more tumors that we would otherwise miss with white light cystoscopy.
Bladder cancer affects 80,000 patients each year in the United States, and approximately 3/4 of these are non-muscle invasive in the earlier stages of disease, and about a fourth of them are muscle invasive. The two categories are treated differently. In the patients who have non-muscle invasive bladder cancer, we tend to treat with intravesical treatments or treatments that are in the bladder with medicines that are directly placed inside the bladder. For the muscle invasive disease, a little bit more aggressive disease, and therefore the treatments are more involved, typically involving chemotherapy prior to surgery and surgical removal of the bladder, or possibly trimodal therapy, what we call trimodal therapy, which is resection of the tumor, removal of the tumor with a scope first, followed by chemotherapy and radiation. We have many different treatment options available for patients. We have many clinical trials that are testing novel treatments for bladder cancer. And it's exciting times right now because there are lots of novel treatments coming up for bladder cancer. We're leading some of those clinical trials. In terms of radical cystectomy or removal of the bladder and reconstruction, we remain one of the top centers for offering the various reconstructive options, particularly what we call continent urinary diversions, or the ones that are reconstructed inside the body, such as the neobladder, a new bladder made of the intestine. We've performed more of those than most centers around the world. And so we have vast experience in continent urinary diversion. And in terms of management with medicines and chemotherapy, we have all kinds of prospective urinary biomarker studies, serum tumor marker studies, and imaging studies to hope to better identify and also better treat patients at an earlier stage of disease, and therefore lead to better outcomes.
So currently, the robotic approach at our center is offered to any patient who is a candidate for radical cystectomy. If their cancer requires their bladder to be removed, then all patients are candidates for a robotic approach. In men, usually it requires removal of the bladder and the prostate. In women, we can either remove just the bladder, or sometimes it also requires the removal of the uterus and part of the vagina, depending on where the tumor is located. Bladder cancer and radical cystectomy can be done both open surgically and using robotic techniques. At USC, we've been one of the pioneers in developing robotic cystectomy here, where not just the removal of the organs, but then the subsequent reconstruction or what is called as urinary diversion is also performed robotically. So the entire process is robotic, compared to many centers where they only remove the bladder robotically, but then they perform the reconstruction portion through an open incision. The utilization of robotic surgery is increasing, and we are proud that we are one of the centers that have helped lead it in a responsible way.
Enhanced recovery after surgery is a multimodality strategy for helping patients to get better as quickly as possible after surgery. And what that means is there are several interventions before surgery, such as nutritional interventions, educational interventions, and then after surgery, multiple things as well, such as limiting narcotic medications, using non-narcotic pain control, using exercise, early walking, several dietary supplements to help patients get their bowels back on track quickly so they can get out of the hospital quickly after surgery. And actually, using enhanced recovery, or ERAS, we've been able to decrease our postoperative length of stay from around 7 days to actually only about 4 days after even radical bladder surgery. Not only do we offer every type of surgery that a patient could need, whether radical surgery or non-radical surgery for bladder cancer, but we also have a multitude of clinical trials available to patients, both in the non-muscle invasive space as well as in the muscle invasive space, or even metastatic bladder cancer space. So in the post-surgery setting, part of our comprehensive recovery from bladder cancer includes working with our enterostomal therapists, who are expert nurses working in patients with bladder cancer. Because we've had such a long and robust experience here at USC with bladder cancer, our nurses really have seen every type of urinary diversion issue or problem or question that can come up, and are a fantastic source of support for both patients and their families.
Stoma care is our urinary diversion where the urine flows automatically to a pouch. And those pouches are changed either every 3 days, or we set you on a schedule of changing them twice a week. There's a lot involved in the stoma care. And one important thing that we do is pre-surgery, we get to meet you ahead of time and actually show you all the ostomy products. We've got demos. We get to do some hands-on crafting and teach you before surgery how to change your ostomy pouch. And then after surgery, we take the time to come meet you and your loved ones at the bedside and do hands-on training throughout your hospital stay to ensure that you feel comfortable with doing the ostomy care on your own. And oftentimes you know plenty more than the nurse that's visiting you. Our goals here at USC are to have patients reach their full potential. Despite whatever has gone on medically and whatever they're undergoing surgically, we want to make sure that they recover well, that they feel that they can return, whether it be golfing or swimming or any activities of daily living.